that. Okay, so we are recording, and all right, there we are, back with that, and then I'll save that file and then sign on to the next Zoom session, and we'll just continue from where we left off. Okay. All right, so here we go. This is going to be chapter 49. This is with diabetes mellitus. And by the way, when you guys do come up, on my screen, you are visible in what is being recorded. So that will be on the recording, so just know that in advance. It's kind of like knowing that you're on a conference call. So we're going to talk about diabetes mellitus, and you know that diabetes is a chronic multi-system disease related to the abnormal insulin production. It's impaired insulin utilization, or both. It affects 25.8 million people. It's the 7th leading cause of death. Currently in the United States, an estimated 25.8 million people, or 8.3% of the population, has diabetes mellitus, and 79 million more people have prediabetes. In approximately 7 million people with diabetes mellitus, the disease has not been diagnosed yet, and they are unaware that they have the disease. The annual cost of diabetes exceeds $174 billion, and $116 billion is directed at medical costs. I think when I was doing my master's degree, it was estimated that in the year, I think it was 2010, that 1 out of 5 children born that year would be diagnosed with diabetes by the time they got to their adulthood, which was staggering to me. Diabetes is the leading cause of adult blindness, end-stage kidney disease, non-traumatic lower limb amputations. It is a major contributing factor for heart disease, stroke, hypertension. Long-term complications. Adults with diabetes have heart disease death rates 2 to 4 times higher than adults without diabetes. The risk for stroke is also 2 to 4 times higher among people with diabetes. In addition, it is estimated that 67% of adults with diabetes have hypertension. So there is significant problems with this disease. So when we talk about the etiology and the pathophysiology of diabetes, you know that it's either the absence or the insufficient insulin, or the poor utilization of insulin that causes the disease. The average amount of insulin secreted daily by an adult is approximately 40 to 50 units, or that breaks down to about 0.6 units per kilogram of body weight. So that's for normal insulin production. So normal production is, insulin is produced in the beta cells and the islets of Langerhans. It's released continuously into the bloodstream in small increments, with larger amounts released after food. The stabilized glucose levels we expect to see in a range of 70 to 100 milligrams per deciliter. So here's a visual for you. Hopefully we eat 3 times a day. Of course, we all know in nursing school we kind of eat almost all the time because it's a stress relief. But the red arrows kind of show a peak where you're eating, and then where the blue line peaks is where your insulin production peaks right after you eat. So you'll notice then after dinner you eat, and then it goes way down, and that's a time of fasting basically, because we don't typically eat at that point. So here's what insulin does. It promotes glucose transport in the skeletal muscles and adipose tissues. It promotes storage of glucose as glycogen. It inhibits glycogenesis. It enhances fat deposits. It increases protein synthesis. It's not necessary for glucose transport in brain and liver and blood cells. So you know glycogenesis is the synthesis of glucose from non-carbohydrates such as amino acids and glycerol. So can you guys go on mute for while we talk, because I'm kind of getting some feedback. So insulin is also known as the storage hormone. So when you eat, your body is stimulated to make insulin. And when you sleep, you go into a fasting mode and your insulin production drops. So glucose is stored in the liver and the muscles, and the fat are, so as your insulin production drops, glucose is stored in the liver and the muscles and the fat, and that's becomes a fasting time for you. That's why we like to have those fasting blood sugars drawn in the morning, because most people don't eat overnight. Okay, so we also have these things called counter-regulatory hormones. Those are the glycogen, epinephrine, growth hormones, and cortisol. And these guys work in the periods of fasting. So like when you're asleep or when you're purposefully fasting, when insulin is not working, and they help maintain normal blood sugars in those times. They oppose the effects of insulin. So when insulin's not working for you, the counter-regulatory hormones are. They stimulate glucose production by the liver. They decrease the movement of glucose into the cells, and they help maintain a normal glucose blood glucose level. All right, so classes of diabetes, we have type 1, type 2, gestational, and other specific types, and we'll talk about all of these. But there's a table. It's on page 1154 in your book, and it's table 49.1. And let me just flip over to that. I was doing something else in your book. But that's probably going to be a pretty good table for you to look over. And I'm going to give you some clues here, you guys, as we go along for your test. But that's going to be a good table for you to look over.
What page is that on?
1154. It's table 49.1. And it's just a comparison, excuse me, of type 1 and type 2 diabetes. Okay, so type 1 diabetes, and this was, we used to call this a long time ago, juvenile diabetes. It accounts for about 5% of all cases of diabetes. The onset is in people usually younger than 40 years. The incidence is increasing. It occurs more frequently in younger children. It's usually an autoimmune destruction of beta cells, and it is the total absence of insulin. Yeah, so this is an autoantibodies disease where the body almost always attacks itself and kills the islets of Langerhans in the pancreas. The manifestations develop when the pancreas can no longer produce insulin. Then there is a rapid onset of ketoacidosis, and it necessitates the use of insulin then for the rest of the patient's life. And then the patient has to have insulin, an exogenous source of insulin or an outside source of insulin to sustain life. There's been a lot of new kinds of techniques with insulin delivery, and one of the big things has been an insulin pump, and we'll talk about that in a little bit, but that has really helped a lot of people. There's also something with newly diagnosed type 1 diabetes called the honeymoon period, when they're first newly diagnosed, so sometimes for 3 to 12 months after their treatment is initiated. Sometimes patients require very little injected insulin because the beta cell insulin production remains sufficient for glucose control, but eventually those beta cells are destroyed and the blood glucose levels increase. And that honeymoon period ends, and they then do require insulin for the rest of their life. So just know that there is such a thing called a honeymoon period, and that may happen. Okay, so type 2 diabetes And my slide did not change. There you go. Pardon me?
I was just going to say, it shows up on ours that you changed it.
Yeah, but I've got a second computer that I'm using that you guys can't see.
Okay.
I have notes on it. So type 2 diabetes is also formerly known as an adult onset diabetes. And you can see all those cute little abbreviations, AODM, or non-insulin dependent diabetes. It is the most prevalent type of diabetes, 90 to 95%. The risk factors for that include overweight, obesity, advancing age, and family history. There is an increasing prevalence in children, and there is a greater prevalence in ethnic groups. And you need to know this, what I'm about to tell you. And those ethnic groups are African Americans, Asian Americans, Native Americans, Native Hawaiians or Pacific Islanders, and Hispanics. And that's going to come up in another slide, so we'll repeat those. But African Americans, Asian Americans, Native Americans, Native Hawaiians, Pacific Islanders, and Hispanic. And for these ethnicities, they have a higher rate of type 2 diabetes than do just plain old white folks. So here's an audience response question. So the nurse plans a class for patients who have newly diagnosed type 2 diabetes. Which goal is most appropriate? I'll let you read through the responses. What do you think? Anybody have an answer?
C?
All right. C is actually a very good answer. Enable the patient to become active participants in the management of their disease, because the goal of diabetes education is to enable the patient to become the most active participant in his or her own care. Good choice. All right. So the pancreas continues to produce some endogenous insulin in type 2 diabetes. Sometimes the insulin is insufficient or it's poorly utilized. And there's multiple etiological factors. Obesity is a great risk factor. Genetic component increases insulin resistance and obesity. So both of those are things that can affect type 2 diabetes. So let's see. So we can treat type 2 diabetes with diet and lifestyle only. Insulin may be used to treat diabetes and complications from type 1 or type 2. Insulin is not necessarily going to be used in type 2, but it's always going to be used in type 1. Insulin is always going to be used in type 1, not necessarily in type 2. Type 2 can be treated with simply diet and lifestyle changes. Before planning a teaching with a newly diagnosed diabetes patient, assess the patient's perception of what it means to have diabetes. Their perception may have to be expanded somewhat, so you need to know where they are with the disease before you can teach them anything. Does that make sense?
Yeah.
Okay. Okay, there are 4 major metabolic abnormalities: insulin resistance, a decrease in insulin production by the pancreas, inappropriate hepatic glucose production, and then altered production of hormones and cytokinins by adipose tissue. And so this is just a little visual depicting the differences, and this is also in your book. That's on page 1155 if you're interested in looking in that. So let's talk about these. Metabolic syndrome increases the risk for type 2 diabetes, elevated glucose levels, abdominal obesity. And I feel like they're talking about me when they talk about this, because in my last few years, I've definitely gotten that abdominal tire roll around my middle. Elevated blood pressure, high levels of triglyceride, and then decreased levels of HDL. So I also want to point out to you, and in your book, and this is in a different chapter, but on pages 921 and 922, there is a discussion of metabolic syndrome. And that's actually in chapter 41, because it goes along with table 4110, but it talks about metabolic syndrome if you're interested in reading about that. So those are pages 921 and 922, and it gives a good little discussion about that. Okay, so we know that type 2 diabetes usually has a gradual onset. We know that hyperglycemia may go for many years without being detected, and many times discovered with routine laboratory tests. I think it's also safe to say that many times people suspect this and just kind of stick their head in the sand and deny that it might be happening to them too. Prediabetes, and this is kind of an important slide for you. So individuals at risk for type 2 diabetes, we can test. And one of the things we do, we look at their impaired glucose tolerance, and we can do that with an oral glucose tolerance test. So when we do that, we look at giving them a dose of glucose, basically, and check them in 2 hours. And if their test comes back in that range of 140 to 199, then they are in that range of being impaired glucose tolerant. And that's an indicator that they are pre-diabetic. We also look at their fasting glucose level, and if their fasting glucose is 100 to 125, that means that they are in that category of impaired fasting glucose. That puts them in a pre-diabetes state. Doesn't mean they're diabetic, it means they're pre-diabetic. They can be asymptomatic, but long-term damage is already starting to occur. So it's important to teach patients in this category that they need to undergo screening, they need to manage their risk factors, they need to monitor symptoms of diabetes, and they need to maintain healthy weight, exercise, and healthy diet. Okay? So if you were talking to somebody and they told you that they had a fasting glucose level that was maybe 110, would you tell them that they were diabetic? Probably not. You would tell them that they might be on their way to being diabetic. And actually, I think, well, yeah, let's just go to the audience response question. A patient screened for diabetes at a clinic has a fasting plasma glucose of 120. Which statement by the nurse is best? I'm going to let you read those. D, yes. You are at increased risk for developing diabetes. Okay. All right. Okay, gestational diabetes. This is diabetes that's developed during pregnancy. It increases the risk of need for cesarean delivery and perinatal complications. And it increases the risk for cesarean delivery because you usually have large babies. We screen high-risk patients first visit, others at 24 and 28 weeks of gestation, and usually glucose levels normal at 6 weeks postpartum. So it's an indicator that if you did have gestational diabetes and you're normal then after pregnancy, you may down the road be at risk for diabetes. And I think actually I know that there's a 35 to 60% chance of developing type 2 diabetes within 10 years. Is anybody out there had gestational diabetes with pregnancy?
Me, and it's been 11 years since I had him.
Okay.
Alicia.
Alicia, okay. I actually had 2 babies that were over 9 pounds, which fits this criteria, but I was never gestational diabetes.
I
So
only had it with my first, not with my second. And my second one was bigger than my first. Whatever.
yeah. So I always kind of walk backwards and think that diabetes might be sneaking up on me, but hopefully it won't. All right. Other specific types of diabetes, it can be a result from damage to injury to or interference with or obstruction of beta cell function to the pancreas. It can be from medical conditions and or medications. And it can also resolve when underlying conditions is treated or medication is discontinued. So what this is saying is if you're taking medications such as corticosteroids like prednisone, or drugs such as thiazides or phenytoin, another name for that is Dilantin, or some type of atypical antipsychotics, they can put you into a state of diabetes. But when those are taken away, you can recover from that. There are other syndromes or other medical conditions that can put you into a state of diabetes. You may not come out of that, but some of these can be Cushing's syndrome, hyperthyroidism, recurrent pancreatitis, cystic fibrosis, hemochromatosis, and then the use of parenteral nutrition. Now, if you're using parenteral nutrition and you stop using it, you probably will not be diabetic. So those are some other causes. So here's some classic symptoms: polyuria, frequent urination, polydipsia, excessive thirst, polyphagia, excessive hunger, coupled with weight loss, weakness, and fatigue. So if you are going to assess somebody for diabetes, knowing these symptoms, what do you think you might ask them as far as questions go?
Have they had any unexpected weight loss lately without trying? Or
Great question.
Also, are you feeling more tired recently? Have you been experiencing any weakness? Having a hard time getting up in the morning?
Do you have to pee a lot?
Right, all good questions. So if you had a multiple guess question that had something like that, you'd be able to pick those out, correct?
Well, we're good.
Okay, good. Let's see. I think I just went backwards on that one. There we go. Okay, and I just got a notification that I'm probably going to lose this session in about 5 minutes, so we'll keep going. Non-specific symptoms of type 2 would be fatigue, recurring infection. Okay, well, let me back up for a minute, because type 2 diabetes could also show you the classic symptoms of type 1, but they can also simply show you fatigue, recurring infection, recurring vaginal yeast infection or candidal infection, prolonged wound healing, and visual changes. So diagnostic studies, we're going to look at a hemoglobin A1C level, and we're going to hope that it's not higher than 6.5, but that is the threshold, 6.5. Some places will say 6.5 to 7. Fasting plasma glucose level higher than 126. 2-hour plasma glucose level with an oral glucose test of 200. And then the classic symptoms of hyperglycemia with a random plasma glucose level of 200 or higher. Yeah, okay. And I think this one talks about, goals with our A1C. We want a goal of less than 6.5 to 7. We want to use a diet. Okay, so with the A1C, it's used to reflect the glucose level over the last 2 to 3 months. And I think we talked about this last week, didn't we? That it was used to diagnose and monitor response to therapy and to screen patients with prediabetes. And I think we also talked about the American Diabetic Association identifies the hemoglobin A1C goal for diabetic patients as less than 7, but we really want that to be 6.5 to 7. So, all right, collaborative care. We want to decrease symptoms. We want to promote well-being. We want to prevent acute complications. We want to delay onset of progression of long-term complications that include micro and macrovascular. And we're going to talk about those in a minute. We need to maintain blood glucose levels as near to normal as possible. We need to teach nutritional therapy, drug therapy, exercise, self-monitoring of blood glucose. We need to talk about diet, exercise, and weight loss. And all patients with type 1 require insulin. Okay, exogenous insulin are insulins from an outside source. It is required for type 1 diabetes. Have I said that enough that you guys have that? It's prescribed for patients with type 2 diabetes who cannot control their blood glucose by other means. So insulin is always for type 1 and sometimes for type 2. Human insulin is genetically engineered in laboratories. It is categorized according to onset and peak action and duration. We have rapid, short, intermediate, and long-acting categories of insulin. This chart is going to be very important for you to know. This is in your book, and it is on page 1158. This talks about insulin, and it gives you the onset, the peak, and the duration. When we talk about giving insulin, we're very interested in the peak time, because that's the time when a patient's blood sugar can bottom out. So as an example, I'm going to look at, let's say Novolog. That is on the top category. That's a rapid acting. That has an onset of 10 to 30 minutes. So if I was going to give this to a patient, when would I want to give that in relationship to a meal?
Um, 10 to 30 minutes before a meal?
Well, I would want to know that the meal is going to be there, right?
Yeah.
I would actually want to make sure that the meal trays are actually in the hallway and that someone's going to be walking in the room with a tray within 10 minutes. I wouldn't want to give that an hour before trays are supposed to be there.
Okay.
Okay. I know it's going to peak in 30 minutes to 3 hours. So let's say we're talking about a noon meal. And so I gave the insulin at noon and they ate at noon. What time would I be looking at to expect a peak?
12:30. Oh, wait. For which
Up
one? I'm sorry.
So if they ate at noon, I gave them the insulin at noon. Their peak is going to be anywhere from 30 minutes to 3 hours. What's my time frame for a peak?
12:30 to 3.
Right. So any time in there, I should be sticking my head in there multiple times to make sure they're not suffering from hypoglycemia, that I haven't bottomed their blood sugar out, correct?
Yes, ma'am.
Okay. All right. So that's something very important for you to know.
I don't understand as far as, so the insulin is raising the blood sugar or is it lowering it?
It's lowering the blood sugar.
Okay.
But the problem is if you give too much insulin or the patient doesn't have food in time, the insulin will lower the blood sugar to the point that it's too low.
Okay.
Okay.
So it's lowering the blood sugar.
Right.
So that when they eat, we're checking to make sure that either like they ate enough to keep it steady. Okay.
Right.
Okay.
And what what you're talking about is a problem with diabetics in general, because it's hard to regulate. What we're trying to do is mimic what the body does automatically, and it's very hard to do. So in order to do that, we have to predict an eating pattern for them, and people can't always predict what they want to eat tonight. You know, when you get up in the morning, you can't predict whether you're going to be extremely hungry or you're going to have a headache or whatever. Your body does that automatically. It'll respond to what you eat, and it'll raise your insulin level because you've eaten a meal. And we can't predict that quite as easily.
Okay.
Okay? All right. So there's a couple of things about insulin regimens. This is a basal bolus regimen. It's most closely mimics endogenous insulin production. It's rapid or short-acting bolus insulin before meals, intermediate or long-acting basal background insulin once or twice a day, and with a goal near normal glucose level of 70 to 130 meals before meals. There are less intense regimens can also be used. So you would put a few of these together and try and get them to peak at different times. We also have insulin preparations. We can have a rapid acting, so if someone's blood sugar is high, we can give them a rapid acting insulin and bring it down. And the onset is within 15 minutes. We can give them a short acting. That is an injection that's peaks within 30 to 45 minutes, or acts within 35 to 40 minutes. And then we also have basal background insulin. It's used to control glucose levels between meals and overnight. And then we also have long-acting Lantus and Levemir, and they're released steadily and continuously with no peak action. They're administered once or twice a day, and you do not mix these with any other insulin solutions. So these are a one-time shot. Once a day usually, and then you would mix the others depending on what you think you're going to need. But it's all a guess.